All right, now I'm going to demonstrate for you how you would go through the second column, which is going to be lower cross syndrome and lower extremity. So that first box there, we're going to give you 3 pairs. You need, or your proctor is going to give you 1 of each of those pairs. So I'm going to show you what that would look like first, and then I'll run through the others that I didn't get to. So let's say your proctor tells you iliopsoas, rectus femoris, and the hip adductors, okay? So, morning, I'm Student Dr. Aaron Laughlin. Is it all right if I begin a physical exam?
Absolutely.
All right, if you can go ahead and scoot down to the end of the table so that your legs are kind of hanging off and lay on back for me. So to check for piriformis, we're gonna keep the leg largely extended or most extended, but we can do the Thomas test for psoas. So if you can then reach and grab your other leg and pull it back, we're looking to see, and pull it back to your chest, we're looking to see if this other leg lifts off the table. It does not, so then we ask the patient to switch legs. And pull your leg back to your chest. This one does lift off the table a little bit, so we might say some left hypertonicity for psoas. To then modify it to then also check the rectus femoris, we can bend the knee here and test for hypertonicity. And I'm going to take this leg, drop it, pull that one up, and we'll bend the knee here and test for hypertonicity. And that then isolates more of the rectus femoris. You can relax your leg. And also a little hypertonic on her left as well there. And then for the hip adductors, if you can lay on back. For adductors, we are going to abduct the leg. So just swing this one out, stabilizing the other side, and swing the left leg out. And so there was more motion with the left leg, so we'll say that the right leg has tight adductors. To then also test for the other 3 then, we might have the patient roll over onto your left side. And if you can scoot back to the edge of the table, watch it here so you don't fall off. Just bring this top leg back and let it drop. And we're kind of seeing how far the leg falls off the table. And this is going to test for quadratus lumborum. All right. And then flip over to the other side. Off around the table here. Also watching the back so your patient doesn't fall off. And drop this leg off. And this one seems to go a little bit more, so we'll say that the right leg has tight quadratus lumborum. You can roll over onto your back. We test for tight hamstrings, classic leg lift. And a little less here. Knee begins to bend early. So right has tight hamstrings. And then for piriformis, we can do the Faber test on the left and Faber test on the right. And right doesn't drop down to the table as much, so we say tight right piriformis there. So that should be all for the first box. For our second set, we're doing lower extremity screening, and for that we're going to want the internal, external rotators, the tibiofemoral motion, and fibular head glide. So internal, external rotators. So we're going to externally rotate for internal, internally rotate to test external, and to the other side. Externally rotate, internally rotate, and I'm not finding restriction really on either side. Somebody's doing their stretches. Maybe some restricted internal rotation here on the for the left leg. So we'd say tight external rotators, which is interesting because when we do our Faber test, your piriformis is tight on this side. But that may not matter for this. So External rotators. So also, so maybe tight internal rotators on the left. This leg was externally rotating more. So tight internal rotators on her right leg, tight external rotators on the left leg. For tibiofemoral, if you can sit up for me, and you can assist your patient to sit up. We're going to test for flexion extension bilaterally. So maybe for just a screening, we can, one, palpate along the joint line. So finding where's that, the femoral condyles dropping down onto the tibial plateaus. Kind of feeling, is there any deformity? No, on the other side. These are both your real knees.
Yeah.
Fantastic. So maybe we then have them extend the knee. Good, and bring it back. And can you turn your feet out? Good, and turn your feet in. Good. And so the left leg seems to lag a bit behind the right, so I'm gonna focus in on the left leg. So, I bring it here, and we do some anterior motion, posterior motion for flexion extension, and I think that we are flexed. It likes anterior glide. Then we can test internal and external rotation, and it is externally rotated with anteromedial glide. And then we can test AB adduction. Interesting there. Because you like lateral glide here, but on your rotation, so then I guess I'd modify my diagnosis and say internally rotated with posterior lateral glide, because she also then does prefer varus motion with lateral glide, saying it's abducted or adducted, my goodness. Then for fibular head motion, you can just kind of give a little springing on either side. And the left side is also restricted here. So to test, is it anterior, posterior? We can pull the foot up, which should bring the fibular head anteriorly. Push the foot down, should take it posteriorly. And it does not like anterior motion with dorsiflexion. So we would say the fibular head is in posterior medial glide preference. So there you go. So next up would be your counter strain. Just like box one, they're going to ask for 3, but here you have 6 options, but they're all pretty close together. So you can have the patient lay down on the side, or I guess they can lay down on their back, and that'll actually work very well, because then they don't really have to flip left and right and left and right. It's good golly, that's ridiculous. So we can kind of take the knee, just give it a wiggle to find where's the greater trochanter. So on the greater trochanter, we're looking for that lateral trochanter tender point. Any tenderness right there?
Yep.
A little bit. And so then if we fall a little bit more to the back, we're searching for that posterior lateral trochanter. Any tenderness there?
Not too bad.
Okay. And you can check bilaterally. Tenderness here.
No.
Tenderness here on the posterior lateral side.
Not bad.
No. So then, while they're here, you can also just kind of pull the knee up, or down, and test for medial meniscus. Anything here?
Yep.
So finding the femoral condyles, walking down to the plateau. There's the joint line. Walking medially along that joint line, we'll come across that medial collateral ligament, and there we would find our medial meniscus tender point, which she reports as positive. If we walk laterally along the joint line, find that lateral collateral ligament. Any tenderness there?
Not really.
Okay. Yeah.
Okay.
Then the patient can roll over onto their stomach. We have the medial and lateral hamstrings. We are asking for the distal tender point, not the proximal. So if we can, on those medial lateral condyles, walk superiorly a little bit, and we'll be in the muscle bellies of both of those hamstrings. Any tenderness here?
Yeah.
Right there,
Yep.
yes. And any tenderness laterally?
No.
Okay, so we would report positive on the medial hamstring, negative on the lateral hamstring. You don't need to name them for what they, for the muscle bellies, like semimembranosus, semitendinosus, or biceps femoris. Just finding medial or lateral distal hamstrings is all we ask. So there you go.